So I'm going to talk about the healthcare aspects of the National Day Rally. Again, as usual, these do not represent any official views, but I am speaking as a member of Marua and of the SDP Healthcare Panel, which is still alive, by the way. Now, if you want to know in detail what are some of the issues that were raised in the National Day Rally, I would suggest that you go to the MOH website because it very nicely details them. It's got usual happy families and the comment here. So it breaks it down. Okay, this came out very soon after the rally itself, and the key announcements identified here were firstly the focus on affordable healthcare, affordable outpatient care, and more help with large hospital bills. So in terms of outpatient care, the first thing was to remove the CHAS scheme age criteria. How many of you know what is CHAS?
Yes.
Yeah, you know, right? Anyone on CHAS? No. Okay, and that's part of the problem. See, CHAS is the what they call the Community Health Assist Scheme, which is actually on paper a very good scheme because it allows people to get subsidized care at general practitioners. So these are people who are more responsive. The GP is at the base of your flat. One of the problems is the number of people who actually access the scheme itself. And previously it used to be for older individuals, but now they recognize that children and young people also will need to do that as well. The next category is the subsidies at specialist outpatient clinics, and this is a little bit worrying because the comment is made that these subsidies will be increased to the low and middle income patients. The implication being that the fees will probably go up, but there will be a means testing so that those who, this is what they call targeted subsidies. So again, it's very important to make sure that you pass the means test. And MOH will also study further liberalizing Medisave use, ensuring that Singaporeans continue to have enough Medisave for their retirement needs. Again, if you translate that, there will be the ability to use your Medisave, but the requirement may go up for the Medisave minimum sum. On help with, so that's the outpatient, okay? Right now, Medisave does not cover very much of our outpatient care, and I'm going to go into that in a bit more detail. Large hospital bills, greater assurance for healthcare bills with a revamped MediShield called MediShield Life, and it will offer this term which they use called universal coverage, which is a very emotional term, and it's also got very different meanings. So I'm going to go into that in a bit more detail. Give better protection against very large bills. And again, there's been a hint about what that means. And what that means is that there may be a lifting of the cap. But again, this is going to be a consultation, so we've got a chance to go into this in more detail. Just the last few days, we've had more details emerging on the MOH website. Removal of the qualifying age, better coverage for chronic diseases, and what they've done is they've added, previously there was diabetes, hypertension, chronic heart disease. Now they've added a few others. Including osteoarthritis, which is, you know, when you have when you grow old and your legs start aching, prostate problems, anxiety, Parkinson's disease, and kidney disease, which is good. Charges at specialist outpatient clinics will be lowered by enhancing subsidies for lower and middle. So again, same hint, the charges are going to go up, but they're going to means test it so that those who want to get downgraded or enjoy the subsidies will do that. And then this MediShield, again, very similar. Lifelong coverage for everyone. So this whole term universal coverage, what does it mean? Okay, does universal coverage mean that everybody is forced to buy this insurance? And I think that's the current MOH interpretation of it. Universal coverage means that it's a kind of compulsory insurance that you cannot run away without buying. But this is somewhat different from the way the rest of the world views universal coverage. And I think the best definition of it comes from the WHO, which is obviously the World Health Organization, and they should know about this. So this was the World Health Report 2010, where Dr. Margaret Chan pointed out that universal coverage is all people within a country should receive some degree of financial protection from the cost of at least basic health services. This means that no one in need of healthcare should risk financial ruin as a result of having to pay for care. And she made this point: access to basic healthcare is a fundamental human right, as stated in the WHO Constitution, of which Singapore is a signatory, and not just a privilege to be enjoyed in a few wealthy societies. But this right hardly matches the reality. In many countries, the rich receive all the healthcare they need, while the poor are left to fend for themselves. Fortunately, in Singapore, there is a safety net. So the poor are not left entirely to fend for themselves, But the concern is very much with the sandwich class, who may not be that poor enough. So again, this is from the SDP healthcare plan, where Leslie Chu has pointed out for us. There's this fear that people will abuse free healthcare. See? And so this guy says to him, do you mean that you would go for an open heart surgery just because it's free, even if you don't need one? And he says, no, but that's only because I don't have a heart. See, and I think the reality is very, very, very few people will choose to get cancer or heart disease just because it's free. See, and this is the whole concept of moral hazard, which right-wing economists believe that if you allow free healthcare, people will just take it for no reason. But that may apply to acute, say, body sculpting or something like that. And nobody is talking about getting free body sculpting. Okay, what they're talking about is if you get cancer, why should you have to, sell your house to pay for treatment of cancer, which you did not choose to get? See, and I think that's the fundamental idea which the WHO Director General is talking about. Human rights, people think that they have got nothing to do with Singapore, but again, the people in this room know. Human rights are very much a part of our history. In the 1950s, we had great human rights defenders who came forward to lead us. And another point to note is that Singapore has had a very good healthcare for many, many years. Okay, and there's a lot of talk about the white paper, right? And some people talked about how the white paper should actually have been a green paper. A green paper is something that people consult on. And actually, before that, there was a blue paper. Okay, and this is the blue paper on the National Health Plan, which was put out by the Ministry of Health in 1983. Okay, and this is when, at that time, in 1983, all the hospitals were public hospitals. Okay, there was no such thing as a restructured hospital. All the polyclinics, all the OPDs, the kampong clinic, maternal and child clinic, all entirely run by the government. Okay, they were not run by some privatized company or some corporatized institution. And at that time, Singapore had a health performance which was better than the US and the UK in terms of the infant mortality rates, in terms of the life expectancy. So on a fully government-run healthcare system, we had better healthcare than the US and the UK in 1983. Okay, so it does not mean that the Singapore government cannot do a good job if they were to run the whole thing themselves. See, so this idea that the private sector can do a better job than the government is simply not true. And the evidence is Singapore up to 1983. See, is that the government ran the healthcare, and they did a pretty darn good job of doing it. The problem is that they were worried about the financing, okay? And in the same blue paper, they raised this point, that in countries with a prepaid healthcare system, the demand for medical services outstrips the financial capacity to supply them. They talk about overloading the system, lowering the standard of healthcare, the need to balance the demand and capacity to supply. So there's a fear, again, the fear of overconsumption. So fast forward to today. Okay, right now, total health expenditure is about $12 billion. Government health expenditure is about $3.5 billion. It's about a quarter to a third of the health expenditure. These data are from the MOH website. And the 3 M's, and this is from before the National Day rally. Okay, if you go to the MOH website, you'll see that there is this universal coverage is already there. Because their understanding of universal coverage is that there's a safety net, and there is a safety net in Singapore. Okay, if you run out of your MediSave, your MediShield, you have no money, you've sold your house, your parents, your children have got no more MediSave, MediShield, then the government will step in, see, with MediFund. So there is, nobody in Singapore is denied healthcare. Okay, that is an important point. And so the 3M system is designed as a safety net, and these are the cornerstones of, or so-called cornerstones of our healthcare financing system. But in reality, see, they form only a small part of the total health expenditure. And this is a WHO discussion paper where they pointed out at that point in time, this is about 10 years ago, MediSave, MediShield, and MediFund accounted for only 10% of total health expenditure. 1/3 is government benefits, about 25% is government benefits, 32% out of pocket. Okay, and this is mostly when you go to the GP, right? You pay cash, right? That's a lot of significant expenditure there. And 1/3 is actually employer benefits, and this is an important point. See, so like for me, the university has got pretty good medical benefits. I have a card, I can go and see the panel doctor or whatever, and the employer pays for it. But unless you can rein that in, it's just not sustainable, see. And that has been a lot of the motivation for healthcare reform in many other countries. The government provides insurance so that companies do not have to provide that insurance, and that actually is good for the SME. You see, if everybody in Singapore was covered by some kind of universal health insurance, your company wouldn't have to pay a rising premium to look after you. See, so that's another point to take note of. Okay, so the actual data, this is from, again, MOH website. Medisave, 761 million, Medifund, 84 million. And Medifund, as I said, has got its limitations. This is from one of my patients. Please first exhaust self and immediate family members' Medisave accounts. Okay, then you get Medifund. So it's a safety net. There is universal coverage. If you've got no money, no home, no nothing, you can get help from the government. MediShield contributed another 386 million. And you look at the premiums collected and the amounts that they've paid off. And in fact, it's got many exclusions. At the moment, it doesn't cover pre-existing illnesses. It now covers congenital illnesses for children born after 1st of March 2013. The premiums are also very high, and the elderly pay more. If you're 84 years old, you pay $1,100 every year for your insurance, and a lot of older people cannot afford to pay that. So there's been a lot of talk about so-called front-loading, where the young people pay more to support the older people. It remains to be seen whether that will happen. The second issue is the deductibles. Now the deductibles for older people for a C class is $2,000. You know what's a deductible, right? You have a car insurance, a car accident, you bang into it, you pay the first $500 or so. But for MediShield, government health insurance, the deductible is $2,000 for C class, 80-year-old. Okay, so that means they have to pay up the first $2,000, then MediShield will kick in. So MediShield is not designed for your normal hospitalization. It's designed for catastrophic hospitalization. If you get really, really sick, you get some very complicated kind of cancer or something like that. And the cost of hospitalization actually is very high. If you look at the costs in government hospitals, open ward for cardiac surgery, for example, okay, the 90th percentile for the National Heart Center is 5,500. So the first 2,000 is already paid up in cash. The rest of it is from MediShield. And in fact, yesterday at a conference, Dr. Jeremy Lim pointed out that MediShield is the world's most profitable public insurance company. So, I don't really understand why there's a need to raise premiums just to keep this MediShield life affordable. So going back to the WHO again, so Dr. Margaret Chan, who looks like an auntie, and she actually is an alumnus of the NUS. She did her master's, she's from Hong Kong, she did a master's in public health at NUS. She's our most distinguished alumnus, so don't look down on her, okay? And she made this statement: direct out-of-pocket payments at the time of care are the single biggest barrier to universal coverage. Okay, that means the co-payment, is the single biggest barrier to universal coverage. And this is an important point. They keep talking about universal coverage, but universal coverage must do without this. You see, while user fees have been promoted as a way to reduce overuse, this is not what happens. They punish the poor, they're inefficient, encourage people to delay seeking care until the condition is far advanced, more difficult and expensive to treat. And when people do pay out of pocket for care, financial ruin can be the result. See, I do rounds on general medical wards in the C-class ward, and it's heartbreaking. I see people coming in with a stroke, and invariably they've been diagnosed with high blood pressure about 10 years ago. See, but they don't go and get their high blood pressure treatment because it's too expensive, or they can't go on the normal drugs. The doctor recommends an expensive drug. Next thing you know, they end up coming in with a stroke. And that's just logical, see. And when they end up with a stroke, they cost the taxpayer, they cost the system a huge lot more money than if you had to just subsidize their treatment for their high blood pressure. So this is what she means, you see, is that these out-of-pocket payments are a barrier to universal healthcare. And what they do, punishing the poor and inefficient, and you end up punishing the whole system as a whole. So very few people in Singapore buy insurance. And again, when you're young, you think that you're going to live forever, so people don't do that. And the result of which is that there's a huge amount of out-of-pocket exposure. This is the out-of-pocket costs that are paid, and this is from a paper in Health Economics, where Singaporeans pay much, much more in out-of-pocket than Hong Kong, Taiwan, Japan, or Korea. In Hong Kong, the bulk of it is paid by taxes. In Japan, the bulk of it by social insurance. Taiwan, bulk of it by social insurance, some private insurance, in fact, in terms of government contribution, Singapore actually is more than Korea or Taiwan. But there's no social insurance. The MediShield contribution is actually very small. So that's why the out-of-pocket becomes so high. And the result of which, as I mentioned, is that people don't get the care that they need. You've got stories of people who haven't seen doctors for years. As I mentioned, this is a study done by NUS students and staff in Taman Jurong area. Many people don't go for treatment. The monitoring is too expensive, the cost of treatment is too expensive, and essential screening often is not covered, which is why they're trying to introduce that for MediSave. And the result of which is Singapore public hospitals have $110 million in outstanding patient debt at the end of 2011. And in fact, if you go to Credit Counselling Singapore, you'll realize that medical costs are the #3 reason for indebtedness in Singapore after overspending and job-related issues. So we believe that no one should have to go bankrupt because of healthcare. And again, this is another of Leslie's cartoons. Your MediSave ran out. How would you like to settle the rest of the bills? By cash, by check, by credit card, by selling your house, or by selling your kidney? So fortunately, we haven't quite reached that stage yet. But the result of this has been the overcrowding in hospitals and unequal access to care. This is Dr. Bill Xiao, who's one of the world authorities on healthcare, and he has critically reviewed the MediSave system. So as I mentioned earlier, the current approach is unsustainable because of healthcare cost inflation. And this is from a paper about 10 years ago, where you see government expenditure actually has gone up, but far more private expenditure has gone up, and total expenditure has gone up significantly. This is in terms of Singapore's healthcare costs. And you go to the CPF website, you see here healthcare bills are rising 11% a year. So healthcare inflation is outstripping regular inflation. And there's an urgent need for a new healthcare plan which is affordable, sustainable, and universal. 10 years ago, the government came up with this, actually more than that, almost 20 years ago, another white paper on affordable healthcare. And this is remembered best for the thought that Singapore had too many doctors. So what they did was they cut the medical school intake to 150. And you know, when you make a change like that, it's going to take 10 years before you see the long-term effect of that. And unfortunately, the result of that is we've had to bring in a lot of doctors to fill in the gap. But one of the comments made in this white paper was that even with MediSave, which is really patients' own money, experience has been shown that patients are more ready to spend their MediSave balances than if they had to pay cash. Hospitals can therefore pass on excessive costs to patients by prescribing more tests and treatments than necessary, or simply by raising charges without losing patients. And this was actually addressed to restructure hospitals, because one of the key elements there was to put caps and guidelines on how much hospitals were allowed to charge. But that has kind of fallen by the wayside. And so this is one alternative, again, marketing, SDP healthcare plan. It was put up by a panel including a couple of specialists, general practitioners primarily, and it involves doing away with the 3 M's, replacing it with a single-payer government-run insurance system with an affordable premium. So what it is we took the total health expenditure, divided it by the number of CPF members, and we worked out that with a raised government subsidy to the level of, say, Taiwan or Korea, and you'd find that the contribution is about $600 per year for somebody earning more than $1,500. If you were poor, the government should pay for that, and if you were a younger person as well. So all of the details are on the website, and there's an additional partial subsidy for those who cannot get it. This idea of a comprehensive universal health insurance means it covers you for both outpatient and inpatient. It doesn't wait until you get sick to cover you, which is what the MediShield Life is all about. And it also controls how much the doctors can, and it's like the Taiwan system, you know, there's a very strict set of rules. The GP cannot just claim that he's charging you, you know, for some fantastic treatment and then expect to get it reimbursed. And it can be done, okay, the sums are there. And in fact, Bill Xiao again, he says, before you can set up a healthcare system for any country, you have to know that country's basic ethical values. Do people in your country have a right to healthcare? If the people believe that medical care is a basic right, you design a system that means anybody who is sick can see a doctor. If society considers medical care to be an economic commodity, then you set up a system that distributes healthcare based on the ability to pay, and the poor are pretty much left out. So again, we believe healthcare is a basic human right. I don't think that the current tweaks that are in there, they address the most obvious glaring gaps. Okay, you know, why should someone who's 91 years old be excluded from MediShield, which he has paid for all his life? So that's an obvious glaring gap, and it's good that they are addressing that. But I think the changes have to be a bit more fundamental. And again, on the website, you can see this is the The current system, which is the co-payment component, which is our MediSave, which is our own money, the MediShield is about this size. Under the SDP plan, the co-payment is there, but it's a smaller component compared to the insurance component, which is much larger. And of course, the elephant in the room is what happens. This is when we are dealing with a population of 5 million right now, and only 10% of them are over 65 of age. When we start dealing with an older population and 6.9 million, which is achieved not by increasing the number of babies, but by plugging in 30 and 40-year-olds who are going to be over 65 in a very short period of time, then I think this is going to be a real huge issue that has to be dealt with. So that's essentially all I have to say. Thank you.